Well, thank you all for joining us. I'm Ann Williams at KTDRR at CEDL in Austin, Texas, and I will be moderating today's webinar entitled Going Beyond Design, Going Beyond Intervention, the American Academy of Neurology Clinical Practice Guideline Process and Other Approaches. This is the second in a series of 4 webinars focusing on systematic reviews, from evidence to recommendations. Before we begin, I'd like to go through some of the Adobe Connect logistics. You all should be listening to this presentation through your computer speakers. And if you have any questions or comments, please type them into the chat box on the left side of the screen, and Marcel or I will address these as appropriate. We have cart captioning that's available, and the link to the cart is in the Useful Links pod on the right-hand side of the screen, and it will open a link to another window when you click on it. Finally, a PDF and a text version of the PowerPoint are available in the pod labeled Useful Documents, so if you'd like to download a copy, please feel free to do so now. I'd like to thank my colleague, Stephen Boydston, for his logistical and technical support for today's session. This webinar series is offered through the Center on Knowledge Translation for Disability and Rehabilitation Research, or KTDRR, which is funded by the National Institute on Disability and Rehabilitation Research. KTDRR is sponsoring a community of practice on evidence for disability and rehabilitation research, and this series of webinars addresses systematic reviews with a special focus on what is considered evidence and why and how this evidence is qualified, synthesized, and turned into recommendation for clinicians and other practitioners. Now it is my pleasure to introduce Marcel Dijkers from the Icahn School of Medicine at Mount Sinai. Dr. Dijkers is research professor in the Department of Rehabilitation Medicine and the senior investigator in the Brain Injury Research Center. He is also the director of the NIDAR-funded Disability and Rehabilitation Research Project on classification and management of medical rehabilitation interventions. He is the senior investigator for the New York TBI model system funded by NIDAR. Dr. Dijkers has published more than 120 articles and chapters on disability and rehabilitation research. So without further ado, Marcel, are you ready?
I'm ready. Thank you, Ann. And we have Ann today as our hostess because Joanne Stark, who normally takes care of these duties, is on the road, out of the country, actually in Toronto. So we're very glad to have Ann, and I'll get into it now. Our objectives are unchanged from what you saw previously. We want to get a conversation going about what do we consider evidence and why. How do we massage research results to have evidence, and how does it from there become recommendations? So today is the second in a series of 4, and I'll skip through this. The last time at our first session, we talked about the role of research, specifically clinical research, in the decision-making of practitioners, with quite some discussion of primary studies and how those might have been turned into evidence-based practice resources. We went over the process of creating a systematic review, how that is done, what are the steps. We talked about the meaning of evidence and the need to evaluate the quality of evidence resulting from clinical research. Talking about what generally people call design, and which I like to call design with a big D. Is it a randomized clinical trial versus a pre-post study versus a single subject design, etc. The quality of evidence is determined by that, but also what goes on with what I like to call little d, which may be referring to quote-unquote details of designing and implementing research like are the subjects being blinded, or what's the percent of follow-up that's being achieved, etc. And then we talked about the hierarchies for evidence relevant to interventions developed by Sackett, which is already 30 years old and more or less is the whipping boy I chose. We also looked at Cicerone, which is close to 15 years old, and if we would ask Mr. Cicerone, he might wish that he could start from scratch and do it all over with a more sophisticated approach. We talked about checklists and rating scales for evidence quality, such as the JDAT scale and the Pedro scale, beloved by psychotherapists or physical therapists, as we call them this side of the border. And we discussed possible uses of checklists and rating scales. So, if you have any questions about what I've spoken about this far, up to and including what was presented the last time, please don't hesitate. In the meantime, I'll go forward to the next slide. There is more to evidence-based practice than randomized controlled trials. And a lot of these slides will just have the abbreviation, so try to keep in mind what those three-letter abbreviations mean. Of course, RCTs are relevant to if we want to collect information, specify evidence on prognosis, diagnosis, screening, etc., etc. And we may need, if other research designs are relevant, we may need different hierarchies for the other purposes for which we do systematic reviewing. We may have multiple hierarchies, one each for a specific research question type. And indeed, those have been developed since Sackett published his simple hierarchy for intervention studies. One is produced by the Oxford Center for Evidence-Based Medicine, and they have in quick succession presented two iterations of what they propose, and we'll go a little bit later back to the 2009 hierarchy, but first let's talk about the 2011 hierarchy of evidence. So they distinguish 6 different questions that people who are into evidence-based medicine, and from my perspective, we might as well say just the same evidence-based practice in other disciplines, questions that people may have. How common is the problem? Is this diagnosis or the monitoring test that we're using accurate? Questions of diagnosis. What will happen if we don't treat this patient's prognosis? Does this intervention actually help? What and how strong are the treatment benefits? What are the common harms that we can expect from this treatment? Then what are the more rare harms? And lastly, if we're talking about screening for particular conditions, is it worthwhile to do this screening? And here we might think about such things as breast cancer screening. And you're probably aware of the big fight that have existed and still exist, whether it's worthwhile to do that. So if you reference this to what Sackett did, The brown column, this intervention help, is the only one that is hierarchy created. So the Oxford people have to provide five more. Before we get into some details, some notes, the scheme that you can find on the Oxford website is optimized not for people who create systematic review, but for the people who need to use evidence, especially people who need to do that quick. I like to call that bedside evidence-based practice, where you discover a particular problem in one of your patients and you wonder, should I treat that? If so, what's the best way of treating that? Let's see, what does the evidence say? Now, generally, you as a practitioner would be happiest with finding a systematic review that covers your question. So for the Oxford people, systematic review is always the highest rank in their hierarchies. Also a very high one is one that is unlikely to ever occur, which is an N-of-1 trial, that was conducted with the patient that the clinician wants to treat. So essentially an N-of-1 trial, it's a terminology that comes out of medicine, but it's a single subject design with a very long A-B sequence, randomized, etc. So yes, if you want to treat a patient with a new problem, you grab for the literature. The number one would be the systematic reviews. You probably, if you already did an N-of-1 trial, that would be even better to do. So, how common is the problem? And I'm going to quickly through these because you can look them up on their website. The URL has been provided as quickly as I do. And most of these things are not necessarily something that needs to be discussed in depth. So how common is the problem? First of all, you would like to have local and current random sample surveys from your area done very recently. Second, you would like, second best, systematic reviews of surveys that at least provide information on populations that are similar to the population you're dealing with. Third best, and local, non-random sample. Fourth best, and case series. And case series very often already consist out of 100% people with the problem. So, what are you going to say about how common is the problem? And there is no level 5 for this particular hierarchy. Number 2, is this diagnostic or monitoring test accurate? The highest is in systematic review of cross-sectional studies with consistently applied reference standard and blinding. And you will notice that I've highlighted a few words in red. Those are the more subjective terms that are used in these standards, that Oxford not necessarily gives an answer for. So if you ask, well, what does consistently apply mean? There is no answer. You have to come up with your own criterion. Level 2 is individual cross-sectional studies with consistently applied reference standard and blinding. Number 3, non-consecutive studies or studies without consistently applied reference standard. Non-consecutive studies would mean the patients being studied were not a consecutive series. Number 4, case control studies or poor or non-independent reference standard studies. And number 5 is essentially there was no studies, but it's reasoning based on somebody's or the practitioner's knowledge of how disease works, mechanism-based reasoning. Prognosis, level 1, systematic review of inception cohort studies. Level 2, individual inception cohort studies. Level 3, cohort study of control arm of a randomized trial. Level 4, case series, case control studies, or poor quality prognostic cohort study, and there is no level 5 here. Treatment, does this intervention help? This should be an extension more or less of Sackett. Level 1, systematic review of randomized trials or N of 1 trials. And there is a plural S here, which would suggest that it could be a systematic review of N of 1 trials, or maybe it's a mistake, and level 1 is either you have at hand a systematic review of randomized trials, or you have in hand an N of 1 trial that you did on this particular patient. And I presumably will have to contact them to clarify that. Level 2, randomized trial or observational study with a dramatic effect. Number 3, non-randomized controlled cohort or follow-up study. Number 4, case series, case control study, historically controlled studies. And level 5 again, reasoning based on one's knowledge of the physiology, etc. Common harms. Systematic review of randomized trials, systematic review of nested case control studies, or N of 1 trial, and here it's a singular trial, with the patient you're raising the question about, or observational study with a dramatic effect. Level 2, individualized randomized trial, or by exception, in exceptional circumstances, an observational study with a dramatic effect. And I realize now that this would equate an observational study with a dramatic effect. It could be in level 1 or level 2, so that's another one that needs to be clarified. Level 3, a non-randomized controlled cohort or follow-up study, for instance, as done in post-marketing surveillance, provided there are sufficient numbers to rule out a common harm. Level 4, case series, case control, historically controlled studies. Level 5, mechanism-based reasoning. And second to last, what are the rare harms? In order to get an idea how common are rare harms, you really need to study large numbers of cases, which either is in systematic review, or some other studies that at least included large numbers of subjects. So even an N of 1 trial, one might wonder whether a random sample N of 1 trial will be sufficient. Level 2, randomized trial or observational study with dramatic effect. Level 3, non-randomized controlled follow-up, etc., etc. For long-term harms, the duration, of course, must be sufficiently long. Level 4, case series, case control, historically controlled. Level 5, mechanism-based reasoning. And lastly, for screening test, ideally, the randomized review of, systematic review of randomized trials, Second, a randomized trial. 3, a non-randomized controlled cohort follow-up. 4, case series, case control, historically controlled studies. And level 5, mechanism-based reasoning. Now, if you paid attention, you will have noticed here, that there's randomized trials, and here's randomized trials. Aren't we talking about a screening test? We'll get to that later, either today or next week, that the optimal optimal evaluation of a diagnostic test is to have a randomized trial in which, in one arm, patients are diagnosed with one test. In the other arm, they are diagnosed with the alternative test. And now we look at what do clinicians do to treat these people and what long-term effect is there in terms of the patient health status. So, the best to evaluate diagnostic test is not which one has the best relationship with a reference test, but in the end doesn't make any difference. So we'll get there in due time. Okay, already, this is what I did, my apologies, and we'll put this one back in this corner. Already called your attention to the subjective elements that were in some of the Oxford language: consistently applied, poor standard, poor quality cohort study, dramatic effect, sufficient numbers. These are all subjective calls for which you get no guidance, and which make it difficult to apply the Oxford standards, whether that's for systematic reviewers or for people who want to do bedside evidence-based practice. And we will be talking next week about grades and how they not necessarily solve the problem, but force a systematic reviewer or ask a systematic reviewer, A, to make a decision, B, to justify that decision, and C, describe how they applied the decision on what, for instance, is a dramatic effect and what is a non-dramatic effect. Now, if you go to the Oxford website, do not get scared that how you see the evidence hierarchies is like this. They are not vertical with one higher than the other, but the 6 questions are stacked on one another, and you have from left to right the range of qualities of evidence. And one of the reasons I think they did this is to emphasize that asking the right question is just as important as considering the evidence in a hierarchy, because the hierarchy, as we saw, is not necessarily the same for each question. As a matter of fact, there are some dramatic differences. Okay, there are footnotes to the Oxford 2011 scheme where they say level may be graded down on the basis of study quality, which I have been referring to as small d, imprecision, which refers to a wide confidence interval, indirectness, the PICO of the study does not match the PICO of the clinical question, the studies in a systematic review have either a different population than you want an answer for, or a different intervention, or a different comparator, or looked at different outcomes than you think you want to have to make a decision on. But it's close enough that you may want to consider if there is no direct evidence. We have more to say about that next week when we talk about grades. Also, Oxford allows grading down because of an inconsistency between the findings of studies, or between the absolute effect size is very small, and also that comes from grade, and we will pay more attention to next week. According to Oxford, level may be graded up if there is a large or very large effect size. If you treat patients for depression and before treatment they score an average of 26 on the BDI, and after treatment they on average score 21 points, you have done something good for the average patients, but don't flatter yourself. This is just a minor change. But if you would manage to reduce average depression level from 26 to 6, which, if I recall well, is the average for a non-depressed group, you're a miracle worker. How did you do that? You, at least looking at the average, turned everybody from almost certainly or certainly depressed into certainly or almost certainly non-depressed. If you can do something that major, Oxford says and grade says, you can grade up the rating of this evidence. Lastly, Oxford does not offer a scheme to link the quality and quantity of the evidence to the strength of the recommendation. They just, let me quickly run back. There is 1, 2, 3, 4, 5 levels of evidence for 6 questions. Deal with it. How should you act when you have level 1 evidence, and how should that be different from when you have level 3 evidence? Oxford does not tell you. And I'm not sure where that comes from. Now, if you go back to the 2009 grids, they have 4 levels, grades of recommendation. A is when you get consistent level 1 studies. B is when you get consistent level 2 or 3 studies, or you are doing extrapolations from the level 1 studies. C you get when you find level 4 studies or extrapolations from level 2 or 3 studies. And the lowest level recommendation, D, is when you have nothing better than level 5 evidence or troublingly inconsistent or inconclusive studies of any level. However, they bring you a little bit closer to recommendations, but I still didn't find what action they said you should be taking. Now we'll next go over to AAN, where they resolve this problem for us. In the meantime, there should be a slide here reminding me to ask you whether you have any questions about the Oxford Center for Evidence-Based Medicine procedure, and specifically what questions they distinguish, and how they rate evidence for those questions, and at least in 2009 linked evidence quantity and quality to grades of recommendation without being specific. Now let's look at the AAN manual, that's the American Academy of Neurology, and they have what I think is a very beautiful piece of work, their Clinical Practice Guidelines Manual. And here is the link to their website. Oh, the arrow doesn't want to move, but you can clearly see in the yellow box the link, and you can download it for free, and it's a PDF of about 70 pages. So let's have a look. This is the second edition. The earlier edition was from 2004, and they have done tweaking, some small stuff. They also have introduced some aspects of grades into their methodology. Now, supposedly there is to be a 2014 manual which has been finalized by their committee that publishes the manual, but the information I have is that the board of AAN hasn't yet blessed the 2014 edition, so we need to deal with the 2011 edition, which indeed has to be used by all AAN groups that develop practice guideline manuals or guidelines. It's all used by a lot of groups in ACRM, the American Congress of Rehabilitation Medicine, who are developing guidelines. But what probably is its most famous group, Cicerone et al., with their 3 very often quoted systematic reviews, doesn't use it. So let's take a quick look at the entire process before we look specifically at how does AAN say we ought to handle evidence. They start off with you first develop the questions that guide your review and your guidelines. They recommend the PICO formats or PICOs, where the T stands for the time frame, how long after onset of treatment do you want to look at outcomes, and setting may be healthcare setting, what works in socialized medicine in England may not necessarily work in our healthcare system because it's so different. All other questions, whether they concern diagnosis or prognosis, etc., are squeezed into a PICO's framework. For instance, for the screening question, the population is clear, the people you want to screen. The I is doing screening. The C, the comparator, is not doing screening. The O is the outcome of the screening, what you find. T is at what point in time after the screening are you looking at outcomes, and S, of course, is the setting. So they have some discussion of types of clinical questions. Then they talk about the development of an analytic framework. And here's an example of an hypothetical and very simple analytic framework that when you develop a guideline, you generally want to talk about everything that has to do with the management and treatment of a particular group of patients, like everybody who develops carpal tunnel syndrome, or with maybe all the problems or a particular problem that is found in a larger group. For instance, carpal tunnel syndrome in people with traumatic spinal cord injury. So in order to do that, you need to talk about diagnosis, treatment, prognosis, and you can start talking about an analytic framework. Well, if we have a good test, that still might only pick up 90% of the people who have the problem that we're interested in. And then if you have a good treatment, the numbers needed to treat is 4.8, indicating that you need to treat 4.8 patients for every success. And of course, not a single treatment is good forever. People relapse, etc., etc. So if you have to do a prognosis as to what be the situation in 5 years, you may predict only 30% of your sample correctly. So this linking between steps or separate questions and separate systematic review is the analytic framework, and I suggest it may be worth your while to have a look at that. Then the next step, of course, is finding and analyzing the evidence, finding the relevant evidence to identify methodological characteristics of the studies. And I turned this red to indicate we're now getting where we want to be. 3, rating the risk of bias. 4, understanding measures of association. 5, understanding measures of statistical precision. 6, interpreting a study. And then C, the stage of synthesizing evidence and formulating evidence-based conclusions. Accounting for conflicting evidence, and they have a very nice section about how to do that, how to look at conflicts between. Knowing when to perform a meta-analysis, again, nicely written, not technical at all. Their target audience for their manual is clearly clinicians. Wording conclusions in non-therapeutic questions. Generally, therapeutic questions are fairly straightforward, but they have some specific guidance when you have questions about diagnosis, prognosis, screening, etc. And then capturing issues of generalizability in the conclusion. Again, nicely written. If you have information in the studies that were found about a slightly different population or a slightly different intervention or a slightly different outcome measure, how far can you generalize? Or if you're writing a systematic review, what can you suggest how wide this evidence might be used? So let's look at some of more on making practice recommendation, rating the overall confidence in the evidence from the perspective of supporting practice recommendations, putting the evidence into a clinical context, crafting the recommendations, making recommendations on surrogate outcomes, knowing when not to make a recommendation and making suggestions for future research. Some of this we will discuss next week in the framework of grade. Others, I again refer you to the AAM manual, who do a very nice job of this. So I pause here to give people an opportunity to type in any questions. And it looks like nobody took the pen or the keyboard, so let's move. If you're still formulating your questions, don't hesitate to throw it out later. Sarah Woodward has started typing, so let's see what she comes up with, which gives me a chance to rest my voice a little bit longer and take another sip of water. Well, nothing is coming forward from Sarah. If you want to, there it is. What discipline is of clinicians the manual intended for? Therapist, nursing, etc. Well, this was written by neurologists for neurologists. And it indeed has a strong medical perspective, but there is a lot of simply good thinking in there. So if you can put aside the problem you may have with physicians always playing first violin, I would suggest that you skim or even better read this manual just as a good comprehensive background, how responsible attempts at reviewing the literature, finding evidence, using the evidence to phrase recommendations and clinical practice guidelines is done. I'm moving on to AAN details. They have classification schemes for 5 types of systematic reviewing activities or clinical questions: therapy, causation, where they refer to, well, what do we know what causes this problem? This is independent of diagnosing it, it's independent of treating it, but what went before, what is the causal network that may exist that explains why some people have this problem and others don't. Prognosis, diagnosis, and population screening. So it's not quite the same as Oxford, but there's quite some overlap. Well, let's start with what's easiest to understand, therapy. And AAN, in all its 5 hierarchies, distinguishes, defines 4 levels. High is the best. Roman 1 is the best. Roman 4 is the poorest. So if you hear me talk about level 2 study, you know by definition that I'm talking about a study that gives pretty good evidence, but not the top level of evidence. Now, for treatment, the class 1 can only be produced by an RCT in a representative population. And again, I've highlighted in red terms that not necessarily are defined by the manual, but the manual leaves it up to any particular group that applies its methods to fill in some of these things. Relevant baseline characteristics, well, what's relevant, are presented and substantially equivalent between treatment groups, or there is appropriate statistical adjustment for differences. And this is your famous table 1, with 2 columns, one for the treatment group, one for the control group. And you know that we always hope that those will be pretty much the same between the 2. Now, sometimes you have an unlucky hand with randomization. Even if you randomize large numbers of people, you still may have a lucky hand. And yeah, what you can do is in the statistical analysis, use appropriate statistical techniques to balance the two groups out. Also required in these class 1 RCTs is concealed allocation, a clear definition of what the primary outcomes are, clearly defined inclusion-exclusion criteria for the study, and adequate accounting for dropouts with loss to follow-up, no higher than 80%. Sorry, no higher than 20%. And if there are crossovers, people who were assigned to treatment, but by accident or because they refused to show up, ended up in the other group, the numbers of them are sufficiently small to have minimal potential. The last one is applicable only to non-inferiority or equivalence trials, and I will not pester you with that. You can, if you're into those trials, you can look it up. So we have a big issue with AAN that they specify that I can grab, but bullet number 2, you either have to have masked outcome assessment or you have to have objective outcomes. So, what is an objective outcome according to AAN? It's an outcome measure that's unlikely to be affected by an observer, the patient, the treating physician, the investigator in a study, expectation or bias. For instance, we could talk about that in the case of blood tests or administrative outcome data. Mr. Jones was reported to have died or not to have died. Dead or not dead is a pretty objective outcome that we don't quibble too much about who is dead and who isn't. So they distinguish 3 levels, and maybe the Romans here are inappropriate because it may confuse you with the 4 levels, but the best is the investigator and the patient cannot influence the measurement of the outcome. Level 2 is one of them can, but not the other. And level 3 is, both can impact the measurement of the outcome. And there is specification for AAN guidelines, only level 1, as defined here, is objective, which of course creates a major problem for disability and rehabilitation studies where we often cannot blind. If you want to know whether a particular treatment makes a patient less depressed, pretty much the only way that we have to determine whether somebody is depressed or not is to ask them. So, the patient, is the reporter. Now, if you hear that, that's my phone. Somebody's trying to call me, and they will go away in another 2 rings. If you do a behavioral treatment like CBT to treat this patient's depression, there is no way you can hide from the patient that you're treating him with CBT. If you are comparing CBT to some other treatment, and you have to get the patient's informed consent to be randomized, probably your IRB will ask you to make pretty clear to the patient what the 2 options are, or else he or she cannot make an informed decision whether he wants to be in the research or not. And when you give him or her information on what's involved in CBT and what's involved in the comparison treatment, pretty much as 5 minutes into the treatment he or she is randomized to, the patient knows that he is in CBT or he knows he's in the comparison treatment. No blinding, no blinding, no level 1 outcome, no level 1 outcome, on this slide, that means by definition, bullet 2 here, not masked outcome assistant, you cannot be class 1 according to AAM. And we'll have much more to say about that. But let's go to class 2. A cohort study meeting the criteria A through E for class 1, or an RCT that lacks one or more of the criteria B through E in class 1. In addition to being allowed to miss some of the criteria, the person still, or the study still should report all relevant baseline characteristics, and there should be substantial equivalence between the treatment groups, or appropriate statistical adjustment, just like if you have an unlucky hand in class 1. And you still should have master objective outcome assessment, which means that most of rehab research and disability research cannot even be class 2. It ends up in class 3. Controlled studies, including well-defined natural history controls, or patients serving as their own controls. That means pre-post studies, a description of major confounding differences between treatment groups that could affect outcome should be presented. And number 3, outcome assessment is masked, or if it's not masked, it's objective, or if it's not objective, it's performed by somebody who's not a member of the treatment team. So now all of a sudden we start talking about an assessor, who is not controlled by the treatment team, could assess outcomes to still rescue a rehabilitation and disability study for class 3. Which means my former example of treating depression with CBT versus another never would be level 3, because the only person who can report on depression level is the patient, and the patient isn't blinded. Now there's other studies that we do, for instance, comparing 2 different ways of teaching a patient how to do self-care. We can come up with situations where, of course, the therapists know what they're doing, what's the intervention, the patient knows it, but we could arrange for an independent assessor who is blinded to determine objectively on, say, the FIM, what the level of ability of the patient is, and in that way one of our studies could still be rescued. If that can't be done, our CBT study with patient-reported outcome is dumped into class 4, where it's at the same level as garbage studies. Studies that didn't even include patients with the disease we're interested in. Yeah. Studies that didn't even include the interventions or the comparator that we're interested in. Studies that didn't define the interventions or the outcome measures. Or they talk that they had great results, but you cannot calculate an effect size. Our best finally done research by AAN is dumped into the basement. And we have a lot more to say about that. Before I jump to the other hierarchies, a quick word about how AAN links the level of the evidence to formulating conclusions, evidence synthesis. Of course, it tells you to link the evidence to the clinical question, to consider 4 types of information. What's the class of information? Between of all the class of evidence of all studies that you included in your systematic review. Are they level 1, level 2, level 3, level 4? What effect size did you find between treatment and outcome? And here they took on some aspects of grade. And maybe, if there's difference between effect size, maybe you would want to look only at the effect size of the better study. What's the statistical precision of the individual studies? And if you go and pool studies, do some meta-analysis, what's the precision of the pooled studies? And again, this is an aspect of grade they introduced. And then what's the consistency between studies? Are they all pretty much pointing to the same outcome? Treatment X is better than treatment Y, but some had a pretty good effect size, some had a middling effect size, some had a weak effect size, but at least they all pointed in the same direction. Or did you have some that found no difference, some that had a difference, and some that found that, God forbid, the comparator was better than the treatment? So all of that ought to be considered when you go to drawing conclusions. How does AAN characterize individual studies? 1, the highest level, gives you a low risk of bias. 2, a moderate risk of bias. 3, a moderately high risk of bias. And 4, a very high risk of bias. Pretty much, unless you are interested in doing drug studies, whatever rehabilitation researchers and disability researchers study in terms of interventions is either, with a little bit of luck, level 3 or level 3, moderately high or very high risk of bias. Congratulations, all of us. Here's the link of the studies to recommendations. If you have multiple class 1 studies, then you should phrase your conclusion something like, treatment X is highly likely to be effective. If you have multiple class 2 studies or just a single class 1 study, you say you should phrase it, treatment X is likely to be effective. If you have multiple class 3 studies or only a single class 2 study, treatment X is possibly effective, and multiple class 4 studies or a single class 3 study, insufficient evidence in favor or against treatment X. Again, going back to my whipping boy, if rehabilitation and disability studies can never be higher than level 3, with a little bit of luck, and otherwise level 2, we will always not get any higher than a recommendation of our treatment is possibly effective. There you go home. For ineffective therapy, the phrasing is more or less systematically with the same differentiation, but of course reversed. Treatment X is highly likely not to be effective. Treatment X is likely not to be effective. Treatment X is possibly not effective, and there is insufficient evidence in favor or against treatment X. And for all of the conclusions, before you can make an statement about not effectiveness, you must make sure that either the individual study had enough power, or if you do a meta-analysis, the combined studies have sufficient power, or else you are not standing on very solid ground making a recommendation that uses the word not. Okay, before we go on to some of the other type of questions, any questions that you have for me as to what I just went over with respect to AAN and how it goes about looking at evidence for treatment questions? If not, as usual, don't be shy. Type, well, I go on to the next, or type, send an email to Joanne after the session, and we'll try to get you an answer. Okay, let's start looking at prognosis, and I will run through these things fairly quickly, because you can all look up the details in the AAN manual, and they have examples there, so it gives you a good idea of what's going on. Class 1, you should have a cohort study with prospective data collection. Retrospective, of course, puts you into the basement. It should involve a broad spectrum of persons at risk for developing the outcome. Your outcome measurement, the thing that you are predicting, prognosticating, is either something objective, or if it's something subjective, it's determined, without the person not having knowledge of your risk factor, your baseline risk factor. So this pretty much eliminates the patient, because for subjective outcomes, if what you are trying to predict is whether or not he will be depressed in a year, and one of your prognostic factors is whether or not he is depressed now, generally patients know whether they're depressed or not, and we'll still know in a year from now whether or not they're depressed. Whether a year from now, if you ask them, are you depressed, they will link that to what they are now. I was depressed a year ago. I must still be depressed now. Or if they don't do that, that's a different story. But that's the without knowledge of risk factor status. Also, the study to be qualified as class 1 should have its inclusion criteria defined, and you should have successful follow-up of at least 80% of the people you started off at baseline. So what about class 2? Here it can be retrospective data collection, it can be an case control study, but otherwise it still needs A and B here. It also needs the broad spectrum of persons, and the risk factor and outcome should either be objective things or determined by, but without the person who does the determining having knowledge of the status at baseline, or at baseline having knowledge of the status a year from now, which in the case of retrospective studies is possible. Class 3, cohort or case control study, narrow spectrum of persons with or without the disease, dumped automatically in class 3. But you still need to have an independence of baseline predictive factors with outcomes. And then of course in class 4, about anything goes. You may not have people at risk, you may not have people with the risk factor, undefined, unacceptable measures of risk factor and outcomes, or you cannot calculate an effect size. So, what you're going to do. Again, if you have questions about this, please bring them up. If not, I'm going to go on to diagnosis. And I know that for people who are in rehabilitation or disability, clinical work or studies, you don't do much diagnosing. You probably do a lot more assessing. So the diagnosis with its yes, no, sick or not sick, impaired, not impaired, is not necessarily right up your alley, and unfortunately the AN people do not have an assessment category, but there's still some useful stuff in here. So, class 1, a cohort survey with prospective data collection, broad spectrum, disease determination is objective or made without knowledge of diagnostic test result. So the people who do the gold standard test do not know the diagnostic test result, and the diagnostic test result do not know the gold standard test. Inclusion criteria should be defined, and on at least 80% of subjects that were started off in the study, we should have the diagnostic test results. And apologies again for my phone ringing. Class 2, retrospective data collection is okay, but you still must meet criteria A and B. You still have to have a broad spectrum of persons, and you still have to have making of the diagnosis of the reference test and making of the diagnosis with the new test, going on independently from one another. Level 3, cohort or case control study, or other type study, but with a narrow spectrum. You still need independent determination. And class 4, everything that is not even good enough for class 3. Again, if you have questions about diagnosis and how it's handled, Don't be shy. I will go on to evidence synthesis and formulating conclusions, which, if you have followed this, means that if you noted that I skipped population screening, you are right, and my reasoning was that rehabilitationists and people who do disability studies not necessarily are into population screening, but if you are, you know where to find the AN approach. We already talked about this slide, and it's true not only as I originally specified it for evidence relevant to questions of treatment, but also to the other questions, prognosis, diagnosis, etc. Link it to your clinical question. Consider 4 pieces of information: the class of evidence of all your studies, the strength of the association between the treatment and the outcome, or I should have here said between the 2 parts of the equation. In some instances, this is between the association between the findings of the diagnostic group and the diagnostic test and the reference test, or the strength of the association between predictive factors now and status a year down the road, etc. Statistical precision, how narrow is the confidence interval around that strength of association, and how consistent are the studies. Now, if we have conflicting evidence, one study says one thing, another says another, what should we do? Again, AN gives you some common sense guidance. Number 1, try to explain these inconsistencies from the perspective of either systematic error or from random error. You may look at bias, and if there are multiple studies and there are weaker brothers among them, see if you get consistency if you throw out the weak ones and just look at how the stronger studies do it. And if those are consistent, it's certainly fair to base your conclusion on the stronger studies, although you ought to warn your reader that you threw out some weaker studies because they were contradictory. You can look at random error. If you don't necessarily find that all the weaker studies have one direction, or most of them have, while the strong studies go the other direction, you can still look at, well, if your study is small, it always may come up with a finding that is contrary to the trends. So let's look at, what's the power? Are the studies with low power contradictory to the ones with high power? And can I explain stuff that way? Or, if you do a meta-analysis, if there is sufficient homogeneity of the studies, can you come up with a pooled study, effect size with a reasonable confidence interval that will support your conclusion? Another approach is to see whether there are systematic or random error are due not so much to strength of the evidence or power, but how the studies differ from one another in terms of population, intervention, comparator, and outcomes. Are the studies that point one way using the Zoom as a measure of depression, and the studies that point another way, use the BDI as a measure of depression? Well, that might explain it. Or the studies that have weak effect sizes used a strong comparator, while the studies that had strong effect size, used a comparator that really is not anything that anybody believes should be used with patients, because it's such a weak treatment. So there's another possibility to explain differences between study findings based on the nature of the studies. A second item that AAN manual talks about is issues of generalizability. Well, you found an effect over a few studies that were done in the same population with the same intervention with the same or very close comparators, looking at very similar outcomes. Now, how far can you throw that result? If we were to apply this to a different population, would that still work? If we have studies on stroke, how far can we throw those conclusions when our real population of interest is people with, say, traumatic brain injury? So, AN tells you, if you have pretty good findings this far, to look very hard at generalizability. And look at what are the subgroups, and that may be diagnostic subgroups within the group studied, or other things, predominantly males. Well, and I just looked at a study like that last week, where they indeed studied predominantly males. Well, how far does this conclusion work for females? What were the strengths or the doses or the varieties of the intervention studied? What were the comparators? Were the time points after the intervention termination, more or less the follow-ups, pretty much the same? And what were the outcomes? And limit your recommendation so as to reflect the limits of the evidence. For instance, it might be, it's highly recommended that women with problem X receive treatment Y, but the effectiveness of treatment Y for men has not been established. So there you take generalizability into account, and you put a brake on generalizing from men, from women to men, because based on what you know about men and women with this problem and this treatment, you are not confident that it transfers, or you're just generally very cautious. We already looked at the four interpretations of risk of bias, from low through very high bias. Well, it's almost our time. I had taken from a study that I have been involved with, an application or translation of the criteria that AAN has for treatment that was laid out not by me, but somebody else, into a very clear and simple set of steps. Yeah, and you can link this back to the overview of the criteria for therapies. Yeah, what's the design of the study? Yeah, and it's as simple as, if it's a randomized controlled trial, it can be class 1. If it's not randomized, the best is class 2. Yeah, if you have well-defined historical controls, or patients serving as their own controls, it's the maximum class 3. If you don't have a comparison group, a single subject design, etc., it's at best in class 4. So put the class A rating in. My arrow again doesn't want to move, but it goes there at the bottom line in red. You fill it in. Then you go to criterion B, which has three sections. Yeah. Was the person doing the outcome assessment blinded? Yeah. Yes, no, not stated. And this particular study looked at the fatigue outcome, and fatigue by definition is not objective. So we only included questions on the blinding of the outcome assessor, the effect. Objective is still in here. Okay, I would have to, and the independence of the person doing the assessment, and now based on, B1, B2, and B3, if B1 is yes or B2 is yes, you can be no higher than in class 1. If only B3 is yes, you cannot be higher than class 3. And if all three of them are no or not stated, you can be at most class 4. Same story for criterion C, which already spreads over 2 pages, and then in the end you pull it all together. What was the rating for class 1? Was that level 1, 2, 3, or 4? What was it for B? What was it for C? Now the final is the worst maximum that you had for A, B, or C. So you pick the worst maximum, which should be Roman 1, Roman 2, Roman 3, or Roman 4, and there you have your risk of bias. Again, any questions? If not, we're wrapping up this session. If you have questions, email them to Joanne. Her email address is on here, and if she can't answer it, she'll pass it on to me. Steve just provided the link to the evaluation, and of course you are invited to connect to that link and give feedback on today's session. If you have suggestions for what ought to be covered in future sessions, whether that's session 3 or session 4, or as I indicated previously, we're more than happy to cook up either a session 5 or do some more sessions probably after the summer holidays. Please let us know. Otherwise, thank you all for being there in today's presentation. Thanks to Steve and good, as usual, Blink. Thanks to Anne for hosting the sessions today. And all of you, enjoy employing this new gained knowledge. Follow up with getting the AN manual. Next week, we will start talking about some of the stuff that we already have encountered here, either in Oxford or in AAN, but they stole from grades, and look at grades in larger detail. And then the week after that, we will get back to one of the central problems of today, which is, do we have to live if in AAN, the best grade disability and rehabilitation research can get is 3, and the more typical grade for it is level Roman 4, or can we do something about that? So we'll discuss some of that stuff in the session scheduled for 4 weeks from today, in 2 weeks from today. Grades in all its glory. Thanks so much.
Well, thank you very much, Marcel. We appreciate all your insights, and we also appreciate all of your participation today to the participants. Like Marcel said, Stephen had put up a link to the evaluation, so please fill that out. We really enjoy listening to your input, and we appreciate the support of NIDR to carry out these webinars. Our next webinar in this series will be on July 2nd, so we'll see you all in a couple of weeks. Thank you.